three subscription plans. So we have the basic, standard, and the mentorship. Mentorship is a wholesome subscription plan, which we offer as a special rate of 50,000. So here we give you pre-recorded classes as well as live classes. There is also a live doubt clearance. There's one-to-one personalized guidance. We give you notes as well as there is quick revision examination module, which will help you through the exams. So you can use the code Dr. Divya 20 for the discount on subscription. So you can also book a slot for personalized counseling session where further details will be shared. So on internal exam marathon, here it's a 45 duration program where we are giving you rapid revision of all important questions as well as quick revision of volatile facts. Then also MCQs will be covered, and also and with all this, I'm sure you would get top-notch grades in the exams. And this is a wholesome program because here all the university papers or like the exams for all the university states, it will be beneficial. So the questions basically consist of in view of all the other university exams also. So we'll begin with today's classes, that is the fifth series. So here today's objectives are, we will be studying about extraocular muscles, the dural venous sinuses, mainly emphasis on cavernous sinus and the dural folds. Then we will have note on middle ear as well as tympanic membrane. Then short answers on sagittal section of eyeball and atlantoaxial joints. So the first question is extraocular muscles. So since we are emphasizing on how to write the answers, so I'll be just telling you like under what headings you need to write the answer. So here the question should be, when the extraocular muscles are asked, what do we mean by that? That is the definition, the location, origin, insertion, nerve supply action, and applied aspects. So when you know an order of writing the question, it will be easier for you to recall and write. And you need to be specific for these headings. So definition, when we say extraocular muscles, so as the name says, it is coming from outside, extraocular muscles, okay? So these muscles, they are the voluntary muscles, okay? Voluntary muscles of the orbit. So there are 6 muscles here. So extraocular muscles are nothing but the voluntary muscles of the orbit, okay? Of the eyeball. So there are 6 muscles here. Okay, 6 muscles. So there are 4 recti and 2 oblique muscles. So here you can see them. So 4 recti and 2 oblique muscles are there, inferior oblique and the superior oblique. So where are these located? They are located within the orbit. Okay, so the location is within the orbit. So coming to the origin of this is the orbital cavity. So they are present within the orbital cavity. That is all is necessary for you to write. So this here, you can see this is the tendinous ring of Zinn. So all the muscles have a common origin, that is especially the recti muscles, they have a common origin, that is the tendinous ring of Zinn. So tendinous ring of Zinn is present near the superior orbital fissure. So this is the superior orbital fissure where this tendinous ring is present, and all these muscles originate from this tendinous ring. Okay. Lateral rectus has 2 heads of origin. That is one thing you need to remember. So these muscles, that is the recti muscles, they get inserted. Okay, so you can see the annulus of Zinn or the tendinous ring of Zinn. So these recti muscles, they proceed forward like in a cone of muscles. If you see like cone, they are proceeding forwards and they are inserted in front of the equator. Equator, that is near the sclerocorneal junction. Okay, just behind the sclerocorneal junction in a spiral manner. So they are, since the orbit, when you see the orbit, right, it is not like a straight, it is the medial walls, they are parallel of the orbit, whereas the lateral walls, they come converging. Okay, so the orbit is like, you know, it is, the cavity is directed outwards. So because of that, what happens is these eyeballs, they are slightly obliquely placed. So because of that, the insertion is also a little different. So in a spiral manner, it gets inserted. So if you see, the medial rectus gets inserted at about 5 millimeters behind the sclerocorneal junction. This about, that is the inferior rectus, about 6 millimeters, the lateral rectus about 7 millimeters, and the superior rectus at about 8 millimeters. Okay, so 5, 6, 7, 8, like a clockwise it goes. So that is the insertion. So the action of the muscles when we take the, so basically these muscles, so here, superior rectus muscle, we have elevation, okay, elevation. Then there is intorsion, okay, this is intorsion, okay, and adduction. So superior rectus brings about elevation. So if you remember these arrow marks, it is easier to write, okay. So elevation, intorsion, and adduction. Whereas inferior rectus brings about depression, okay, it brings about depression, again adduction, okay, and extorsion. This way it is extortion, okay. Yeah. So from this to like this will be the extorsion, whereas from above downwards here will be the intorsion. Then we have the lateral, so lateral rectus will move laterally like this, okay, lateral rectus, whereas this one, medial rectus, will move medially. Okay, so that is adduction and abduction kind of thing. Means medially it will help to move the eyeball, and this will move laterally. So superior oblique, now oblique muscles, there are superior and inferior oblique. So you just have to mention the origin insertion of the muscles. And next you have to go to the superior oblique and inferior oblique. So here the superior oblique, it has the origin. So if you see from the body of the sphenoid, okay, body of the sphenoid above and medial to the optic canal. So here you can see it has the origin, okay, and it winds around the trochlea. So here it winds around the trochlea at the superior medial part of the orbit. Okay, this we consider as the functional origin, because here will be the pull and the action. And insertion is just behind the equator. Okay, that is just below the, this is the superior rectus muscle. So below that it gets inserted. Okay. And the inferior oblique muscle, it originates from the orbital surface of the maxilla. It passes backwards and laterally below the inferior rectus. Okay, and it gets inserted behind the equator again. Okay, and that is parallel to the superior oblique. So where the superior oblique is getting inserted, there only it just parallel to that it gets inserted. Okay, so the action of these muscles. Okay, so the superior oblique and inferior oblique, if you see the action here, the superior oblique, okay, here this is the superior oblique, it brings about depression, the abduction, and intorsion. Okay, whereas the inferior oblique brings about elevation, the superior oblique, elevation, then it brings about abduction and intorsion. Okay, so these are the movements of the superior, the oblique muscles as well as the recti muscles. The nerve supply of the extraocular muscles. So all these muscles, they are supplied by the oculomotor nerve. Okay, that is superior rectus, medial rectus, inferior rectus, all these are supplied by the oculomotor nerve. Okay, except for lateral rectus and the superior oblique muscle. Okay, so lateral rectus. So we remember it like this. We remember like the, okay, LRs, LR6 and SO4. Okay, LR6 is lateral rectus, is the sixth nerve, that is the abducens nerve. SO4, okay, so SO4, when we say SO4, fourth is the trochlear nerve. Okay, SO4, superior oblique is fourth. Okay, rest all the muscles are supplied by the third cranial nerve, that is the oculomotor nerve. So basically the weakness of these muscles, okay, they will cause the drooping of the eyelids, which we call it as ptosis. Okay, so when you write about the extraocular muscles, so you should remember when you write okay, so what are the things which you will write it under? Extraocular muscles. Okay, so first is definition. Definition is they are originate from the outside the orbital cavity. Okay, they have the origin from the outside the orbital cavity, so they are known as the extraocular muscles. So there are 6 muscles. Okay, there that is 4 recti and 2 oblique. Okay, Nikita, can you tell me which is the common origin for that, for the recti muscles? You can unmute yourself and tell the origin.
Tendinous ring.
Yes, very good. So the tendinous ring of Zen. So you will talk about, then after you write about what are they and which muscles are they. Once you list it out, then you talk about the recti muscles. So recti muscles, so which is their common origin. Okay, so origin and where it is getting inserted, you will talk. The same way you will talk about the oblique, that is the 2 oblique muscles. So origin and insertion. After that, the action. The action you can make a tabular column. Okay, you can make a tabular column, write the muscles on one side and the movements, what they bring about. Okay, with an arrow mark, like, that what in the diagram it was, you can show it that way. So this is about the extraocular muscles. So this is the summary which you have to remember under what headings you will write it about. The next question is the dural folds and dural venous sinuses. So this question is a very important question, very commonly asked. Okay, so what do we mean by dural folds? So dural folds, so how will you answer? Okay, so here you will answer like this. What is the definition? Okay, and what are the characteristic features of it, the classification of it, and then the clinical importance when we talk about the dural venous sinuses in general. These are the things which you need to follow. So what do we mean by the definition? What will you write there? So dural folds, they are the folds formed by the dural folds are present within the cranial cavity, which is formed by the meningeal layer, that is the dura mater. That is, we have a dura mater has 2 layers, that is the endosteal layer and the meningeal layer. So both these together, they form the dural fold. Okay, so basically it is formed by that. So what do we mean by dural venous sinus then? So dural venous sinus is the venous channels which are present within these folds. Okay, which is present within the dural folds. So we have 4 dural folds. Okay, so if you see here, the dural folds are there. So we have, this is the falx cerebri. The same way below here, there will be falx cerebelli. Okay, so here falx cerebelli, this is the falx cerebri. This is the tentorium cerebelli. And here we will have the diaphragma cellae. So these are the 4 dural folds which are present. And within these folds, we have the sinuses. Next, you will write what are the characteristic features of these sinuses. Okay. So basically, these dural venous sinuses, they occupy the space between the dura mater, and that is dura mater layers, that is the endosteal as well as the meningeal layer. Except if you see here, that is the inferior sagittal sinus and the straight sinus. So these 2, okay, this is one thing you should remember because for MCQ it will be asked. Okay, so which all are within the 2 layers except, okay, which sinus is not there. So within this one here, you are seeing the inferior sagittal sinus and straight sinus. So these are present only within the meningeal layers. They are not present within the endosteal because as such, when we say endosteal, it means which is covering the bony part. Here there is no bone, isn't it? There will be the brain matter there. Okay, so this inferior sagittal sinus and straight sinus are present only within the meningeal fold. That is one thing. Okay. Second characteristic feature is this is lined by the endothelium. Okay, it is lined by endothelium and they do not contain any valves. Okay, so they don't have valves. They do not have any muscular coat. So what do? Okay, next. So they collect the blood from the brain, the meninges, the diploe. Diploe is the portion between the outer table and the inner table of the skull. So this portion, what we see, that is the diploid. So it collects the blood from there. So basically it is draining the blood from different parts of the brain, the meninges, the diploid, okay, as well as from the internal ear and orbit. So from all these areas, it drains the blood. Then next function of these dural venous sinuses, it also absorbs the CSF. It absorbs the CSF through the arachnoid granulations. Okay, so arachnoid granulations are present here. So these are the arachnoid granulations. Through that, it will absorb the CSF. Excess CSF is drained there. Okay, and most importantly here, these are connected to the extracranial venous channels, that is veins, extracranial veins through emissary veins. So emissary veins are valveless veins which connect the extracranial with the intracranial. That is this dural venous sinus. So these are the characteristic features of the dural venous sinuses. Next, coming to the classification. So classification, we have to write, that is unpaired. There are unpaired venous sinuses and there are paired venous sinuses. So unpaired venous sinuses, they all lie in the midline. Okay, if you see, right, because they are unpaired, right? Paired will be right and left. So these are unpaired, so you can just see it in the midline. So when you go from anterior to posterior, we see the superior sagittal sinus, the inferior sagittal sinus, the straight sinus, the occipital sinus, okay, anterior intercavernous, posterior intercavernous, and basilavenous plexus. So these are the unpaired venous sinuses, okay, superior, inferior sagittal, straight sinus, occipital sinus, anterior intercavernous, posterior intercavernous, and here will be the basilar venous plexus. Okay, so this is the basilar venous plexus. So paired sinuses. So paired sinuses are present on either side. So when we come from each cranial fossa, so always remember it in an order from anterior to posterior. So that time, no, you will not forget, you will not miss, excuse me, you will not miss anything. Okay. So we have the sphenoparietal sinus here. Okay. That is at the junction of the anterior cranial fossa and for the middle cranial fossa along the the lesser wing of the sphenoid. Here we'll have the sphenoparietal sinus. Okay. Then middle meningeal vein. Then cavernous sinus on either side. Okay. This is cavernous sinus. Intercavernous are the unpaired. So cavernous sinus, then superior petrosal sinus, inferior petrosal sinus, transverse sinus, and sigmoid sinus. So these sinuses are paired venous sinuses, which are present on the right half as well as the left half of the cranial cavity. Okay, so this is about the dural folds and dural venous sinuses, which you need to write. And always, usually this question is combined with writing a note on cavernous sinus because it is a very important sinus. And why cavernous sinus is very important is because it establishes communication with the different extracranial veins also. Okay. And there is many communicating channels. So infection from anywhere can spread mainly to the cavernous sinus. So how do we write the answer? So we write the answer as definition, location, formation, structures passing through the sinus, its relations, tributaries, then communications and clinical importance. So we'll go one by one. So when we say the definition, okay, what do we mean by cavernous sinus? So what do we write for that? It is a paired dural venous sinus, okay, which is present, okay, location, it is present on either side of the body of the sphenoid in the middle cranial fossa, okay, so it is a paired dural venous sinus present in the middle cranial fossa on either side of the body of the sphenoid. Now, why is it called cavernous? Okay, so when it is, so if you see here, this portion. So here you see a lot of trabeculae, okay? So it gives a appearance of very spongy appearance it gives. So that is why it is called as cavernous sinus, okay? So basically because of the interlacing of these reticular fibers within the sinus, it appears like spongy. So this measures about, okay, 2 centimeters in length and about 1 centimeter in breadth, okay? 2 centimeters in length and 1 centimeter in breadth. Next, you write about how it is formed. So here, if you see, okay, the floor of the cavernous sinus and the medial wall, okay, floor and the medial wall is formed by the endosteal layer, okay, of the dura mater, whereas the lateral wall and the roof it is formed by the meningeal layer, okay. That is one important thing you need to remember. So this much you will write about the definition and location. Next, structures passing through. Okay, to remember the structures passing through, you remember, okay, from above downwards, within the lateral wall of the cavernous sinus, we have 4 structures passing. Okay, so which are those structures? Okay, you remember. Okay, so from above downwards, we have, oh, okay. This is O. Okay, so first O. Okay, so O is for oculomotor nerve. So this is the oculomotor nerve. Okay, T, O tom. You remember O tom. So O is for oculomotor nerve. T is for trochlear nerve. Again, O is for the ophthalmic division of trigeminal. Then we have M. M is maxillary division of trigeminal. Okay, so these three four structures pass through the lateral wall. Then within the cavernous sinus, we have 2 structures passing through. One is the internal carotid artery. Another one is the abducent nerve. Okay, this is the abducent nerve. So these are the structures. So you just have to list. How will you list? Structures passing through the lateral wall. Okay. Can you tell me, Nikita, what are the structures passing through the lateral wall? Yes, Nikita, can you repeat? What are the structures? You remember OTOM and try to, that mnemonic you can remember and say that is oculomotor, trochlear, then ophthalmic and maxillary nerves. Okay, so all these are nerves which are passing along the lateral wall. So these things, okay, within the sinus will be the internal carotid artery and abducent nerve. Next is the relations. Okay, so next you have to talk about the relations. So what are the relations? So medial relations, okay, superior relations, lateral relations, okay, we talk about. So what structures are there when we see, okay. So medially, so if you see here, okay, so this is the medial wall, this side will be the lateral, will be the roof, and this is the floor. Okay, so this is what I meant by saying this 2 is formed by the endosteal, this is formed by the meningeal layer. This is in contact with the bone, here there is no bone. Okay, so now the medially and below, if you see, medially what is there? Pituitary gland is there. Okay, this is the hypophysis of pituitary gland. And here, that is below, will be the sphenoid sinus. You can also say medially, that's not wrong. So hypophysis cerebrae or the pituitary gland and the body of the sphenoid with the sphenoid sinus present there. Okay, so that will be the medial relations. So lateral relations, here they will be the cavum trigeminal. Cavum trigeminal is basically where the trigeminal ganglion is present. Okay, here in this picture you are not able to see, but in the bone, which is in relation to that. Okay, then you will see the uncus. Okay, uncus on this side will be the uncus of the temporal bone. Okay, sorry, the temporal lobe. Uncus of the temporal lobe, that is the curvature, no, where you see of the temporal lobe, that portion will be in relation to this lateral part. Okay, above if you see, there will be optic chiasma. Okay, internal carotid artery is there. Okay, which will form a kind of bending, which we call it as the carotid siphon. So these are the structures in relation to the cavernous sinus. Next, we come to the tributaries and communication. So you can draw this diagram showing tributaries on one side and communications on the other side. Now, tributaries, what do we mean by tributaries? Tributaries are the veins which are draining into this cavernous sinus. Okay, So basically, I told you these venous sinuses are draining the blood from the orbit, from the internal ear, from the meninges, from the brain, isn't it? So like that, they're done from the diploid. So they're draining from different areas. So this cavernous sinus, it drains from the orbit through the superior ophthalmic vein, inferior ophthalmic vein, and the central vein of retina. Okay, so they come from the orbit, these three veins: superior ophthalmic, inferior ophthalmic, and central vein of the retina in an order. Then from the meninges comes the sphenoparietal sinus and middle meningeal vein, which will drain into the cavernous sinus. And from the brain, we have the superficial middle cerebral vein and inferior cerebral vein. Okay, so those will be the tributaries. So communication. Now communication is all these communications which it makes with the different other structures. Okay. Now here we have the transverse sinus. Okay. So the transverse sinus, it will make communication to the superior petrosal sinus. And with the internal jugular vein here, it will make communication through the inferior petrosal sinus. Okay. So through the inferior petrosal sinus to the internal jugular vein, superior petrosal sinus, it communicates with the transverse sinus. Okay. Then with the pterygoid plexus of veins. So pterygoid plexus of veins, it will communicate through the emissary veins. Through the emissary veins, it will communicate with the pterygoid plexus of veins. Then with the facial vein, it will communicate. This is very important because usually the dangerous area of the face, which is in front of the philtrum, that is in front of the nose, right, below the nose, the philtrum part, that is the dangerous area of the face, because any infection there can spread through retrograde spread into the cavernous sinus, and that will be through the facial vein. So one communication will be through the superior ophthalmic vein. Okay, superior ophthalmic vein. So facial vein will communicate with superior ophthalmic vein. Superior ophthalmic vein will go to the cavernous sinus. Now, how do they communicate? Facial vein is coming down, superior ophthalmic is up. Okay, how does it communicate? So you should remember that the head and neck veins do not have valves. So because they do not have valves, they can be a retrograde spread. Okay, so that is why the facial vein has a communication with the superior ophthalmic vein. And superior ophthalmic vein, you know, it drains into the cavernous sinus. Okay, that is one way. And another way is through the deep facial vein. Okay, through the deep facial vein, it will communicate with the pterygoid venous plexus and then that to the cavernous sinus. So that is the thing. Then with the opposite, it will communicate through the intercavernous sinuses. So this is intercavernous. Okay. And through the basilar venous plexus, it goes to the intervertebral plexus. So these are the communications. So you can, with one simple diagram, you can show both the tributaries and the communications. In anatomy, drawing the diagrams is very important. And the last, you will write about cavernous venous thrombosis. Okay, that is the common thing which happens because of the spread of infection, and that will lead to exophthalmos, pulsating exophthalmos, arteriovenous communication. Okay, those will be seen. Okay, so when we write the answer for so dural venous sinuses and this thing, when they ask you the question, you need to mention it under these headings. Okay, so what do we write? So first you should write about dural venous sinuses. No, so dural venous sinuses, what are their definition? That is, they are venous channels present within the dural folds. Then you will write the characteristic features of that. Then after that, you will write about the classification, that is paired and unpaired, paired and unpaired. After that, you when they ask about cavernous sinus, you need to explain it under, again, what is it? Definition, where it is located, okay, that it is located in the middle cranial fossa on either side of the body of the sphenoid. Then you will write about its measurement, why it is called cavernous and all these things. So it measures about 2 into 1 centimeter. Okay. 2 into centimeter. And then structures passing through that is through the lateral wall as well as through it, okay, through the sinus. Then you will write about the relations, okay, relations, then tributaries, as well as you will write about the communication. So this is very important, communications, how it communicates, because that forms the route for spread of infection. Okay, so this is the summary of it. The next question will go to middle year. So middle year is very important, one more very important question which is commonly asked. So here the question should be answered under these headings, that is the definition, the boundaries, the subdivisions, contents, features in the wall, blood supply, nerve supply, and the applied aspects. Okay, so what do we mean by the definition? So definition is this middle ear cavity, otherwise called as the tympanic cavity. Okay, it is an air-filled cavity. Okay, which is a air-filled cavity lined by mucous membrane. And where is it present? It is present within the petrous part of the temporal bone. Okay, so that is its size. That is its location. And the middle ear cavity, it assumes the adult size by the time of birth itself. Okay, so now, okay, so it is the cavity which is so after that, what will you write? So it is an air-filled cavity lined by mucous membrane present within the petrous part of temporal bone. Okay. So this middle ear cavity, it is sandwiched between this external acoustic meatal as well as that is the external ear and the internal ear. So because of that, since it is sandwich kind of thing, what happens is it becomes like a red blood cell, that is biconcave disc. Okay, it is like a biconcave disc. So here, what are the things which are present within that? Then you will write about the contents here. So contents are 3 ossicles are present. So if you can see, there are 3 ossicles, the malleus, incus, and the stapes. 2 muscles are there, stapedius muscle and the tensor tympani muscle. Some blood vessels and nerves are there, which I will be telling you. And then we also see the tympanic membrane here. Okay. So this middle ear tympanic cavity, if you see here, anterior-posteriorly, it measures about 15 millimeters. Vertically, it measures about 13 millimeters. Okay. So it is widest in the upper part, then narrowest in the middle part. Okay. Where it measures about 6 millimeters in width, here about 2 millimeters and 4 millimeters in the below part. Okay. So that they are the contents side. This is what stapedius is. This is the tensor tympani muscle. These are the 3 ossicles. Okay, right. So next is subdivisions. So subdivisions, we divide this tympanic membrane. Okay, so the tympanic membrane, it divides this middle ear into 3 cavities. 3 areas. Okay, so how do we divide that? So above the portion of the middle ear cavity, above the tympanic membrane, we call it as the epitympanum. Okay, opposite to the tympanic membrane, we call it as mesotympanum, and below that, we call it as the hypotympanum. Okay, so now the boundaries. So boundaries, the middle, this is a schematic representation. So if you see, it has a roof. Okay, there is a roof, there is a floor. Okay, anterior wall, posterior wall, a medial wall, and opposite to this side will be the lateral wall. Opposite to medial wall will be the lateral wall. So like that, there are 4 walls, including roof and the floor. Okay, 4 walls and roof and floor. So now you should know the features in each of these: roof, floor, what are the features in each of these walls. Okay, so first is roof. Roof is otherwise called as, so this is the roof. Okay, so I will be switching between these 2 pictures so that you get an idea. So this is the roof. Okay, so which is otherwise here in the actual middle ear, it looks like this. Okay, this is known as the tegment tympani, or it is known as the tegmental roof because it is formed by the tegment tympani here. And piercing through this tegment tympani will be two nerves, that is lesser petrosal and greater petrosal. This is what you need to remember here. So the roof will show two nerves piercing through it, okay, lesser petrosal and greater petrosal. Then we come to the floor. So this is the floor, okay. So floor is here. Floor, here we call it as the jugular wall, okay. It is formed by the jugular. This fossa, what we are seeing here is the jugular fossa, because here we have the bulb of the superior bulb of the internal jugular vein is present here. Okay, superior bulb. This is the internal jugular vein and this is the superior bulb. Okay, so here behind there is the styloid. This is the styloid process. This is the mastoid process. So here, just in front of this jugular fossa, there is a small foramen. Okay, that is known as the tympanic canaliculus, through which the tympanic branch of glossopharyngeal nerve will enter. Okay, and here between the styloid process and mastoid process, there is a small foramen, stylomastoid foramen, through which the facial nerve will emerge out. Okay, so these are the structures in relation to the floor. Okay, so main thing is the superior bulb of the internal jugular vein. In front of that, the tympanic nerve will enter through the tympanic canaliculus into the middle ear cavity, whereas here the facial nerve will emerge out. Okay, so this is the floor. Then we go to this anterior wall. This is the anterior wall. So anterior wall, when we see, okay, here, yeah. So this is the anterior wall. So anterior wall, it's also called as the carotid wall because the carotid artery forms the main structure here. So we see a canal, that is the carotid canal here, through which the carotid artery is entering, okay, along with the sympathetic nerves around it. So this is the carotid canal. And just above that, by a bony plate, the anterior wall is divided into two canals. Okay, so one above one is for the tensor tympani muscle to pass through, whereas the lower one forms the bony part of the auditory tube. Okay, this is the cartilaginous part. This portion is the bony part. So these are the things which we see in the anterior wall. And this is all you have to mention. That's it. Okay, each structure, what is present there, needs to be mentioned. Then we have the posterior wall. Okay, so posterior wall is here. Okay, so this is the posterior wall. Okay, so here, this is how we see otherwise. So posterior wall from above downwards when we come from here. So this line is the posterior wall. First is the additus to the antrum, means there is a passage, there is an opening to the leading to the antrum. Okay, so that is known as the additus to the antrum. Then there is one small area here, this portion here, which we call it as the fossa incudis. Okay, fossa incudis. So the short process of the incus will be in relation, that is at the fossa incudis. No, the short process of incus will be suspended by these ligament, okay, which is attached near that fossa incudis. Then here, the lower part of the posterior wall, if you see, there is a vertical bony canal, which is for the facial nerve. Okay, so the facial nerve will descend through this up to the stylomastoid foramen. And in front of it, there is a pyramidal eminence, which is called as the, this is the pyramidal eminence. And here we have the attachment of the stapedius muscle. So these are the features we see it in the posterior wall. So what do we see from above downwards? The additus to the antrum, the fossa incudis, then the bony canal, okay, for the facial nerve, and the pyramidal eminence. Okay, next is the medial wall. So commonly asked question is this one, that is the medial wall, very important one, medial wall. Okay, so medial wall, what are the things we see here? Okay, so the medial wall, since it faces towards the bony labyrinth of the inner ear, we call it as also as the labyrinth wall. Okay, so here, what do we see? First important structure, what we see is the promontory. This is the promontory. Now, what is promontory? Promontory. So what will you write? What is promontory? You have to write it is a round elevation produced by the basal turn of the cochlea. Okay, cochlea of the internal ear, it will produce this. Okay, the basal turn of the cochlea. Okay, so here on this, this is the promontory, the tympanic branch of glossopharyngeal nerve, these sympathetic nerves around which are present around the carotid canal, they all form a plexus here, which is known as the tympanic plexus. And from this tympanic plexus comes the lesser petrosal nerve, which will pierce through the roof and go to the otic ganglia. Okay. So this is the thing. And just below, behind and above the promontory, there is a depression which is known as the fenestra vestibula, otherwise called as the oval window. Okay, oval window. So this is closed. Okay, this is closed by the base of the stapes. So base of the stapes will be in relation to the oval window. Below and behind the promontory, there is one more opening which is known as the fenestra cochlea, which is otherwise called as the round window. Okay, so this is covered by a secondary tympanic membrane, okay, which separates this tympanic cavity from the scala tympani of the inner ear. Then this portion here behind the promontory ear depression is called as the sinus tympani. So sinus tympani, that depression indicates the presence of the posterior semilunar canal, okay, of the inner ear. So that comes in relation to that. Then we will see the oblique part of the facial canal. The straight part was seen in the posterior wall, whereas the oblique part, we will see it in the medial wall, okay? So where the facial nerve will pass. Then there is this hook-like process. So the bony plate, which was present in the anterior wall, that will project into the middle ear cavity, forming a hook-like process, which is called as the processus trochleariformis. Processus trochleariformis. So this is the thing. Okay, so these are the features which we see in the medial wall. Okay, the promontory, where we see the formation of tympanic plexus. There is the oval window, which is closed by the footplate of stapes. Then this is the round window, which is covered by the secondary tympanic membrane. There is a sinus tympani, which indicates the presence of posterior semilunar canal, semicircular canal, sorry. And we have the oblique part of the facial canal and the processus trochleariformis. Okay, so this is how we will see. This is the petrous part of temple. You can see the promontory, this nerve plexus. This is the hook-like process. This is the oval window, which is covered by this footplate. Okay, the base of stapes. Then this is the posterior wall. Okay, this is the oblique part of the facial canal. Okay, so next we'll move on to the lateral wall. So this was the medial wall which we discussed now. Now this is the lateral wall. Okay, so lateral wall of the what is that? Middle ear is mainly formed. The main structure here is the tympanic membrane. Okay, tympanic membrane we see, and we see the with this thing, ossicles here, ear ossicles, that is the malleus and the incus. Okay, and there are small fissures for the passage of the chorda tympani. So chorda tympani nerve will be passing across the cavity here in the lateral wall. Okay, and here will be the anterior ligament of malleus will be present. So these are the structures we will see. So after mentioning, when they ask you if your lateral wall, you have to mention these structures and then talk about the tympanic membrane here. Okay, so I will tell about tympanic membrane separately. We will deal. So we will finish with the middle ear. So middle ear is supplied by the So middle ear is supplied by superior tympanic artery, anterior tympanic artery, and stylomastoid artery. And other arteries which supply are the petrosal branch of middle meningeal artery, branch from the artery of the pterygoid canal, and tympanic branch of internal carotid artery. So if you just mention, it's enough. Nerve supply is by the greater petrosal, chorda tympani nerve, facial nerve, mandibular nerve. So they supply the middle ear. Okay, so these are the things which you need to write. So when we summarize middle ear, you have to know. So you are only I'll summarize. So the definition, boundaries, contents, features. Okay, so features of each one. Okay, so the roof was. So when you talk about the roof, you will talk about the two structures there. Can you tell me, Nikita, any structures which you remember in the roof? Can you remember and tell me what did you see in the roof? Roof was pierced by roof. You will see two nerves, isn't it? Greater petrosal and lesser petrosal. Floor, we will see floor, you will see the internal jugular vein, okay, as well as the uh, two nerves. Two nerves you will see, the tympanic branch of glossopharyngeal and the facial. Then anterior wall, main structure we will see will be the internal carotid artery, as well as two tubes we will see. That is for the tensor tympani as well as for the bony part of the auditory tube. Then we have the posterior wall. So posterior wall, what do we see in the posterior wall? Posterior wall, adductors to the antrum. Then we will see the vertical part of facial canal. Okay, facial canal you will see. Then you will see the fossa incudis. Okay, and pyramidal eminence you will see. Okay, so medial wall, you will see the promontory, okay, promontory, then oval window, round window, okay, then the tympanic plexus on the promontory, oblique part of facial canal, processus trochleariformis, okay, are the structures which we see there, and sinus tympani. Okay, so that is why medial wall, so many structures are there, it is important. Lateral wall, you will see the ossicles, two ossicles, malleus and incus. Then you see the tympanic membrane mainly, okay, and you see the chorda tympani nerve. Okay, so we will move on to the next thing, that is the tympanic membrane now. So tympanic membrane is written, so it is itself asked as a short essay question. So again, definition, the position, subdivision, surfaces, development, arterial supply, nerve supply, applied aspects you need to write. Okay, so what are the things we will write for definition? So tympanic membrane, common term we call it as the layman term is the eardrum. Okay, it is an oval, semi-transparent, pearly gray, it appears pearly gray, trilaminar membrane, which is separating the external ear from the middle ear. Okay, so it is a semi-transparent, pearly gray, trilaminar membrane. Okay, it has three lamina. So this tympanic membrane, its maximum diameter is about 9 to 10 millimeters. Okay, and minimum is about 8 to 9. So this tympanic membrane, position-wise, it is placed in adults. It is placed little obliquely. Okay, it has an oblique that is at about 55-degree angle with the external acoustic meatus. It is placed. But whereas in children, it is more horizontal. Because of that, children can tolerate loud sounds better than adults. Okay, that is one reason. Next, you have to write about its subdivisions. Okay, so here, now before I go to subdivisions, so here if you see, okay, the circumference of this membrane, okay, so this is the circumference. The circumference is made with this fibrocartilaginous ring, okay, which is attached to the sulcus of the tympanic plate and to the bottom of the external acoustic meatus, it is attached. Okay, so this sulcus is deficient above. So here what happens, here where the two folds will come, two folds, okay, that is the anterior malleolar fold and posterior malleolar fold. Okay, in the upper part you will see these two folds. Okay. So subdivisions. So subdivisions, that is these malleolar folds, here. So the malleolar folds will divide this tympanic membrane into two parts. So this smaller upper part, this is known as the pars flaccida. It is a small triangular lax area above the malleolar folds because here the sulcus is deficient, right? This portion is very lax. Okay. This portion, this is called the pars tensa. Okay, which is very tensely attached. So as the name says, it's quite tense. Okay, so this tympanic membrane, developmentally, you should know that it is derived from all the three germ layers. So that is why it is called as trilaminar in origin or trilaminar membrane. ectoderm, endoderm, and mesoderm. All the three things will be formed, okay? So the portion towards the external acoustic meatus will be from the ectoderm, towards the middle ear cavity will be from the endoderm, and in between will be the mesoderm, okay? So here, this handle of the malleus is attached, okay? And this point where it is the lower end, this is known as the umbo, okay? This portion is called as the umbo here. And when we reflect the light, that is when we do a otoscopic examination, right? There will be the reflection of the light, which appears like a cone of light. Okay, this is the thing which you should know. Blood and nerve supply, it is by the anterior tympanic artery, deep auricular, and posterior tympanic artery, supplies the tympanic membrane. Okay, applied aspect. So applied aspect here, what happens is, usually, see, the middle ear has a communication with the pharynx, to the nasopharynx, no, it communicates, right? So any infection in the, that is a upper respiratory infection can spread to the ear. So sometimes what happens, especially in children, we see a condition called as otitis media. So otitis media, what happens is there is regurgitation of the milk, okay, whatever they take, because there the auditory internal, that auditory pharyngeal part of the auditory tube, no, that will be very horizontal. So what happens is it regurgitates, okay, into the cavity. Yeah? That is why, you know, they ask soon after feeding, they ask to burp the child, not to feed it lying down, okay, to keep a particular position of the newborn, okay, so while feeding. So it's very important. So this can cause infection, and then it forms a continuous, it continues, okay, from acute condition, it leads to chronic. That is called as otitis media. So when there is a lot of collection of pus, so usually normally we see this cone of light, okay, in the posterior inferior quadrant. When this, anterior inferior quadrant we will see, not this is the anterior inferior quadrant, we will see the cone of light, okay. So this will be obliterated. So you can see the cone of light is obliterated by this collection of pus, okay. And since when there is a lot of collection and when it's not treated, what happens? This tympanic membrane can rupture, leading to the discharge. So this is how it is collected. So this is very tense, it is collected, and finally it will rupture, okay. And this has to be repaired. Okay, so these are the things which you need to write it under. So next we go to these smaller questions, that is a membranous labyrinth. So what do we mean by membranous labyrinth? So how will we write the answer for membranous labyrinth? So what is it? What is the definition? What structures are present there? And what is the function and clinical aspects you will write? Okay. So membranous labyrinth, when we say, as the name says, it is the membranous part, okay, which is present, that is within the bony labyrinth. So now this membranous labyrinth, it consists of a closed system of intercommunicating membranous sacs and ducts. Okay, so there are intercommunicating membranous sacs and ducts. It connects. Okay, and it is filled with the fluid which is known as the endolymph. So the membranous labyrinth, what structures are present? It has the cochlear duct. Okay, so you can see here. Cochlear duct, you can see here, right? Okay, so this is the cochlear duct. Okay, so cochlear duct is present within the bony cochlea. Then the saccule and the, so here the cochlear duct, okay, then the saccule, okay, so the saccule and the utricle is present within the vestibule, and the three semicircular canals, okay, within the corresponding semicircular bony canal, it will be present. Okay, so now this membranous labyrinth will have two special functional components. Okay, so one is this cochlear duct. Cochlear duct is responsible for hearing. So this is known as the auditory system. Okay, that is the functional system present within the membranous labyrinth. The saccule and the utricle here, which is present within the vestibule here, right? So this is responsible for balancing. Okay, this is responsible for balancing. So the saccule and the utricle, no, they are responsible for static equilibrium and linear acceleration, whereas the semicircular ducts are concerned with kinetic equilibrium. Okay, static equilibrium, that is when you are in a static position. Okay, so this will maintain when you're standing, it maintains the balance. Then whereas the semicircular canals, they maintain the balance when you are in movement. Okay, so that is the things which you need to write. It is mainly asked as a 3-mark question. Okay, this is how it is present within the bony cavity. Coming to the short answers. So one question is asked as the sagittal section of eyeball. So basically this is asked as to draw the diagram. So you draw the sagittal section of the eyeball and mention the structure. So you need to mention it like this. So mention all the 3 layers. Okay, 3 layers of the eyeball you mention, and then you go from anterior to posterior, showing the cornea. After cornea comes the chamber, anterior chamber, that is the anterior cavity, posterior chamber. Then you have the pupil, the lens. Okay, this is the choroid body, and we have the iris here. Okay, these are all the suspensory ligaments. Okay, so these structures need to be shown, and the 3 layers need to be shown. The fovea centralis and the optic disc here, that is the blind spot. And this is the optic nerve, which will contain the central retinal artery and vein. Okay, so these are the structures you need to draw and show for sagittal section of the eyeball. Okay, so coming to the last question, that is the atlantoaxial joint. Okay, atlantoaxial joint here, it has to be answered under the following headings. That is the type of joint, articular surfaces. So any joint, it is the same headings you need to follow. So type of joint, articular surfaces, ligaments, movements, and applied aspects. Since it is a short answer question, you just have to be very specific. Now, atlantoaxial joints, no, we have 2. Okay, 2 means a median joint and a pair of lateral joints, lateral atlantoaxial joint. Okay, so this joint, basically it is responsible for the no movements. Means like if a question is asked, you don't answer, you just turn your head, that is the no movement, right? Yes is the occipitalo-axial joint. Okay, so that forms the S, whereas this is the no movement. So the medial, so next is articular. So medial atlantoaxial and the lateral atlantoaxial. So medial atlantoaxial, what are the articular surfaces? So it is the odontoid process or the dens of the axis, and the articular facet. Okay, that is here we have the articular facet of the atlas. Okay, so they form the articulation between the dens or odontoid process of the axis and the anterior arch of the atlas. So they form the what is that? Articular surfaces. Okay, the ligament here of this joint is the transverse ligament. Okay, and the lateral atlantoaxial joint. So each joint is a plane synovial. So this is a pivot joint. Okay, type of joint. When we write it as pivot type of synovial joint, whereas this is plane type of synovial joint. So it is formed by the inferior articular facet of the lateral mass of the atlas with the superior articular facet of the axis. Okay, so that one. So here we have these ligaments, that is the alar ligament, the apical ligament. Okay, all these ligaments which will be connecting here. Okay, as well as the transverse, which will help in the what is that, providing support with the joint. Okay, so the nerve supply of this atlantoaxial joint is mainly by the C2 nerves. Okay, and movement is basically it rotates. Okay, so basically the no movements or side to side movements of the neck is brought about by this joint. Okay, so what is the clinical importance? Why atlantoaxial joint is asked is basically death due to judicial hanging. When they do hanging, by the court, when hanging is ordered, it is basically because of the rupture of this ligament. Okay, the transverse ligament of the atlas, or it can be a fracture of this dens. Okay, fracture of the dens, then it presses upon the medulla and then causes death. Okay, so basically it compresses, it is dislocated when there is, if the transverse ligament tear is there, again it is joint is dislocated. If the Odontoid process is cut. Again, it can, if there is a fracture, it can get dislocated, cause pressure on the spinal cord, this thing, and cause the immediate death of the patient. Okay. I mean, the criminal. So that is used in judicial hanging. Suicidal hanging, that is not the cause. Suicidal hanging is by the compression on the vessels. Okay. So that will cause death. So thanks for watching. So you can download the app and you can have more access to the what Auricle offers, as well as you can follow the content on social media handles. So thank you for watching. So till we meet next, bye. Thank you.